The fifth vital sign was reasonable to consider when treating patients in hospitals with pain. Nurses would ask what your pain level is, and subsequently, if a patient had high pain levels.
Dr. Renee Enriquez, thank you so much for joining me today. I'm excited. You shared a little bit about the physical medicine rehabilitation world, Physiatry, as it's more technically known, I guess. The difference between pain management and interventional musculoskeletal medicine. I love that change because pain management comes with some stigma, right? It comes with potential. For the same reason we call we don't call people addicts anymore. We say they have substance use disorder, right? There are words that we use that label people that have meaning, and I think it's important to make sure that we're using the right words. And some people will say, "Oh, we're just getting soft," but I like it. So, why did you choose this world for you?
Well, that's an interesting question because I went into medical school thinking I was going to be a forensic pathologist. And it was
Ooh.
ironic that you sent me a video of a forensic pathologist that you had on your
Our good friend Judy?
Yes, which it was an excellent talk. And
Yeah.
The reason I decided not to go into that was two reasons. One, I realized I was better with live people than dead people. I had really good I really had great patient bedside manner. And the other reason was in order to work in a medical examiner's office, which I did for a short period of time, you had to wait for somebody to retire or to die. And if you wanted to be in Miami, it's literally maybe a few business options open for you. There's only a
Yeah.
few slots. So I decided to pursue a field of medicine where I would be interacting with patients directly, live patients. When I found myself in about third year of medical school, and that's usually when you're going through your rotations, I wasn't liking every discipline. There was some aspects of it, like I liked neurology because they were great diagnosticians. They were able to really diagnose very well. I liked surgery, just the interaction, the hands-on, the proactiveness, but there wasn't anything that fit me. And I think the reason was because I wanted to help people long term. I've always been very much into health and wellness. And the specialty that I felt fit that the most was physiatry, because regardless if you cure somebody or regardless if you diagnose them, they wind up with a disease, a disability, functional incapacities that they live with the rest of their life. And you might not be able to get rid of that. So you have to teach them how to live with that disability or that handicap or with pain. And I think that when you look at a patient in terms of comprehensive management, physiatry fits that because you're treating them not only their physical ailments, you treat their mental ailments, you treat the family. Sometimes you change households. You go to people's homes to evaluate, potential issues that could be prohibiting them when they return back to their life after a traumatic incident or a traumatic injury. And physiatry was basically created out of that. I have a PowerPoint presentation. I'm not sure if you
Yeah.
wanted me to present that.
Yeah,
That
let's
does
do
have
it.
that, but it kind of gets into why I got into physiatry. Am I able to share this with?
Yeah, you should be able to. Me.
Let's go here. If there's any other windows open in here, I apologize. There's nothing inappropriate.
No HIPAA here.
No, no, no. That's on the other screen. We're good. And this will be another technical thing here. So if you want to ask me another question while I'm struggling here as well.
Yeah, I think the question that I have that is most interesting to me is, again, you mentioned, right, this move away from the name pain management. We've had an opioid overprescribing epidemic, at least from the medical side, which is carried over, I think, into the lay population. Obviously, the fentanyl epidemic has been just atrocious. for society. We had a pain scale introduced at some point, right? And when you kind of learn around, about the timeline of the opioid epidemic, we had this pain scale, and pain is the next vital sign that we're treating. I'm interested always to know, like, what are your thoughts about that? Is it valuable, appropriate? Did we just mismanage it? Have unrealistic expectations around it? I'm interested to know your thoughts around it.
It's a very complex question. It's almost like there are so many different factors that evolved all around the same time that it's just one thing is the problem or the fault of, one physician, one patient, one health system. The fifth vital sign was reasonable to consider when treating patients in hospitals with pain. Nurses would ask what your pain level is, and subsequently, if a patient had high pain levels, it would be reported but not necessarily treated, and you would have surgery and be expected to have pain. But in terms of outcomes, and honestly, patient satisfaction, when those surveys started going out a little bit more frequently, patients were saying, well, I was uncomfortable, I was in pain, you were asking me to do things that I wasn't capable of doing. Even in physiatry, the therapy has always been aggressive, but I think that also increased around the same time as we were addressing the pain component. So when patients were reporting that their pain wasn't addressed, and there were studies showing that patients' pain weren't addressed, people started listening. And JACO, which is a body that these young physicians at some point will learn what that is basically a non-governmental body, although the government uses it as such, to kind of evaluate hospital systems and make sure that we're following certain guidelines or certain Medicare requirements. And JACO is the one that kind of pushed that fifth vital sign. So we started treating patients' pain, and it started to become more aggressive, especially in some, I'm not saying I necessarily experienced this, but some were saying that it was affecting patient satisfaction scores to the point where the hospitals were saying, you physicians need to take care of this and deal with this. And so that became an issue of, well, how are we going to treat it? And opiates were being utilized more. They were creating different type of opiates, long-acting opiates, because we initially, very early on in the early 90s even, we saw there was abuse with these medications because of the potential for addiction, because of tolerance and needing higher doses the longer you're on it. So the pharmaceutical companies, which I'm not going to get into again, had created some longer acting medication to try to help curb this addictive component, saying, well, if your pain is controlled and more stable, you won't be having these peaks of, significant pain, or, you won't have these ups and downs. So you won't need more pain medication. There's a good documentaries out there, recent ones on Purdue and so forth. I recommend your listeners watch it. But we later realized that that was not the case. These medications were just as addictive and abusive, even more so, OxyContin being that. And I was training during the time that you would prescribe OxyContin, that we were prescribing that longer acting and adding those additional medications, those shorter acting on top to deal with the peaks of pain. So a patient would have a normal level of 7 out of 10 pain. And instead of necessarily dealing with all the pain components, which is the physical, the mental, and the spiritual, which I believe, we were treating with medication chronically. And then if patients reported increased pain after that, we would give additional medication. So you can understand that now that we're prescribing more pain medication for a symptom of something, and not necessarily treating the pathology causing the symptom, but we were treating the symptom, maybe we were getting better, grades, Press Ganey grades, or what you evaluate your physician in your hospital system. Maybe we were getting, more positive feedback from our administrators, or we were seeing more patients in our clinics, or, we had a lot of positive reinforcement from the community and the hospital system for for this treatment of pain, but it necessarily wasn't benefiting the patient in the long term. And we see that now. We see that in terms of with addiction, abuse. We also see it in regards of our self-reflection of over medicating and sometimes not diagnosing. So
good catch.
That, that's a very long answer for that fifth vital sign, which meant well, but
I love the saying, every system is perfectly designed to get the results that it gets, right? And the system was designed to promote better scores, right? It's for the marketing department to say, hey, look, our patients we're a 5-star rated. But we don't think about those unintended consequences, those downstream effects, especially with these narcotics. So we're backtracking.
Just as a side note, I came into contact with physicians that unfortunately were, a small percentage were abusing, the opiate, the prescribing, we're keeping patients in the clinic for that. But for the majority of physicians that I came across, they really were trying to help. I don't think there was a lot of malice in how the evolution of the opiate and opiate crisis came about.
Yeah, I don't think so. Yeah. I don't think there was malice either. I think it's just these are very powerful drugs that, that just got out of hand a little bit. Awesome. Did we figure out how to share screen?
So it's not giving me that option, and it might just be because of whatever setting I'm on. I'm actually going to email it to you.
Okay.
And if you want to bring it up and be my clicker, I'd be more than happy. And I have to use the other computer again.
Do you have a top documentary that you've watched that you feel encompasses the unfolding of the story as you saw it from a clinical side? Like there's Dope Sick on Hulu and
so believe it or not, I have a problem watching some of these documents. I've seen clips of a lot of them.
Yeah.
And I think emotional because I was kind of involved in that.
Yeah.
There's not one in particular that the name of the one with, is that the one that you're mentioning? The one that I watched with the Purdue family. What's the name of that one? Hold on, I'm just trying to find it. Hold on. Here we go.
The Crime of the Century?
I need that.
Is that it? What is that?
Hold on. MAPD.
Yeah,
Sending you this. Let me know if you get. It's no subject. It's from me.
Okay.
And then I'm going to do a brief here. There is a documentary that I actually make mention in the talk, and it's not about pain, but it's about PM&R, and that's called Murder Ball. Has anybody heard or seen that? Because
are those the roller skaters?
Yes, absolutely.
What do you call
not
that?
Roller skaters. No, they're not roller skaters. They're spinal cord patients who literally play murder ball. It's specialized wheelchairs that are.
Yes.
Have you seen it? Heard of it?
I've heard of it. Yes.
Oh, fantastic.
I was thinking of, what's the one I'm thinking of? The what's that sport that I'm thinking of where they go around in a circle and it's super aggressive on roller skates?
On roller skates. That's a roller derby. That's
roller derby.
The one that I'm thinking of, which does talk about the physicians, pharmaceutical companies, and all that. It's called The Crime of the Century. I think it was on HBO Max.
Yep.
Again, I get a little emotional with some of these.
Yeah.
I also tend not to watch medical shows because of that reason, anything related to what I do. But The Crime of the Century is a good one. That's one here. And are you able to see? Oh, you have it up. Wonderful.
I got it. So I will drive away.
So just to kind of do a quick opening about me, I'm a medical doctor, boarded in PM&R and pain medicine, attending physician here at UT Southwest, which is in Dallas. It is, I'm under the Physical Medicine Rehab department, but also part of the Multidisciplinary Spine Center. That is a big component of what we call interventional pain management, but not pain management. We practice that there at the Spine Center. Assistant professor. I was also assistant professor also at Northwell Health, which is in Long Island, New York. So one of the things I love bringing up about me is I grew up pretty, meager beginnings, honest beginnings. Didn't have much as first family member to go to college, first one to actually have a medical degree. So I didn't have a lot of guidance or support when it came to education. I kind of figured it out all on my own. In figuring this out, I kind of knew I wanted to be a physician very early on. I did have some exposure. There was some great, at least at the time that I was growing up, the 90s, there were some great resources offered through the Department of Health and Human Services. And one of them was called the Hispanic Center of Excellence. And I had the opportunity to rotate as even a high school student in hospitals and help participate with that care. And because of that, I was able to be accepted to multiple programs, both 7- and 8-year BSMD programs. And I decided to go to one where everything was fully paid for. And that was the one that was involved with Rutgers, New Jersey Medical School, and Montclair State University. The interesting thing about that is it's called Rutgers now. It used to be called University of Medicine and Dentistry. So very long title that's now combined to Rutgers. So we just call it Rutgers.
UMDNJ, wasn't it? Like
very good.
Yes,
very good. I did my internship at University Hospital, which is interesting. There is a movie out and a recent movie that did the whole movie is in it's a recent horror movie. I just saw it on the plane, and it's all about University Hospital, which is interesting. It was almost like reliving my internship. I did my residency at Northwell Health. One of the reasons why is there one of the doctors I completely admire, Dr. Adam Stein. He's a master of spinal cord injury, and I thought I wanted to do spinal cord injury by the time I was choosing PM&R. And then I winded up coming back to do my fellowship at Kessler, Rutgers University, associated with that, one of the top PM&R programs in the country for sports and spine. And so depending on what part of the country you're in, when you start narrowing down physiatry into different subsets, you will see sports and spine and you'll see pain management. And they kind of do very similar things. Pain management tends to be a little bit more anesthesia based, where sports and spine can be physiatry heavy based in terms of who's running the program or what department it's out of.
Nice.
So again, just kind of a recap of who I am, but my personal interests outside of what I do. So in not just treating musculoskeletal medicine, so musculoskeletal disorders, knee osteoarthritis, tear of your hamstring, herniated disc. It's also the health and wellness component. I'm a huge proponent of exercise and physical well-being. I've done my own personal practice, and I've studied Eastern and Ayurvedic medicine. And I winded up getting into this complementary care component of my practice because so many people take supplements. So I had to learn a lot just to treat it. And I've now added that and encompassed that in my care. So if you come to see me, I'm treating your back, but then we talk about your weight and what exercise you're doing after your back is better. And then are you taking supplements, and should you take those supplements, and do they wind up hurting you in the long term? And that's kind of like a comprehensive view of my practice with those interests.
Yeah, I bet students would have some interesting questions about some of the complementary healthcare, complementary medicine, because there's always students who are like, I'm really interested in that, but I'm scared to talk about that because of some stigma or something. So I bet you there's some good questions later.
Of course. Physiatry is wonderful because it talks about quality of life. So I'm going to give you a little personal information more than I've already given. I'm married to a surgeon. So we make a joke in the house where my husband, I always say, he saves lives. And then I say, but I make life worth living. And that's really what physiatry is about.
Yeah.
You can keep somebody living a very long time. We have plenty of, medicines and, bio devices that will keep people living, but is it a life worth living? And physiatry really focuses on that quality of life. It talks about not only prevention, and we really go to diagnosing, but our treatment long-term to help people disabled, and disabilities could be as simple as pain, right? You can have a pain that limits you daily in your life, that you can't go to work. You can be overweight and morbidly obese and you can't toilet yourself or transfer. Those are disabilities, even though there still haven't been claimed as true disabilities, depending on what you read. The great thing about physiatry, it's still one of the newer, disciplines. We don't have many new medical fields coming out of there, but physiatry is one of the newer ones, created in like the late 1940s into the 50s. It does work on this multidisciplinary approach, and it focuses mostly on function. So what controls function? Brain, nervous system, musculoskeletal system. And it always adds that health and wellness risk, because we do treat ailments long term. So I always say that although physiatry really started, as an official discipline through the American Medical Association, or the American Graduate Medical Education, in the 1940s, early 50s, it really started as long as go prosthetics and orthotics. You lose a leg, that's physiatry. So pirates and peg legs, I always say. Physiatrists existed from a long time ago. Franklin, FDR, our past president, he had polio, wasn't known to the public, but he underwent aquatic therapy without even saying what therapy was at that point. The father of PM&R, which theoretically PM&R came out of Temple University, although Dr. Cruson started with gynecology in Jefferson Medical School. He was the one who initially wanted to be a surgeon. He was struck in with tuberculosis, and then subsequently took a hiatus, came back and decided to do medicine. And he understood the need to help people with chronic ailments. And then he changed his view, and he is theoretically the father of physiatry. He's had other helps down there with, you'll hear names of Howard Rusk, like Rusk Institution down at NYU, and Simon Barrack, but Cruson is really one of the first ones. A huge component is all at the same time in the 1940s. A big component was during World War II, battlefield medicine improved dramatically. So vets were coming back from war when before they used to die. So in World War I, they would die on the field, and then in World War II, we were able to bring them home. Medicine had improved so much. The sad part was that they all had these disabilities. They were missing limbs. They had brain injuries. They had spinal cord injuries, PTSD even. So with this, the Veterans Affair became a major contributor, and they're probably the biggest proponent of physical medicine rehab. And most of these high technical things that you see come out that are related to physiatry, like walking aids and literally robots that you can attach to yourself now for spinal cord injuries where you can't move your legs, with paraplegics or tetraplegics, those all are funded by, most of them, the Department of Defense, the VA. So the government has played a huge role in PM&R. And there is not one VA in the country that does not have a PM&R department, which is beautiful.
Yeah, which is really interesting, because I went to medical school on an Air Force HPSP scholarship. The Air Force does not have physiatrists. It is a residency that you're not allowed to go into as a HPSP, as a Air Force physician. So it's very interesting with how much we need physiatrists, especially from the Department of Defense with wars and everything. It's very interesting. Yeah, I'm super excited about exoskeletons and the miniaturization of them. Right now, they're still really big and bulky. I would love to put on a pair of pants one day if I have a spinal cord injury, and that is my exoskeleton, and it looks like any other pair of pants. So super, super exciting.
I think with AI, we're going to be there much faster. Okay. So my fingers crossed with AI, but yes. And it is funny. I recently seen the exoskeleton on a newer video, and I was in resident in 2008, and I think 2010, and I saw the same apparatus. So they really haven't shrunk it much. So you're right, but there is some good stuff coming out in the field. For the next slide there. So subspecialties or fellowships. So you will do all this training when you're in physiatry residency, but we focus a lot on spinal cord injury, traumatic brain injury, spasticity. Spasticity is when the muscle tone is much tighter. It's due to improper feedback from from peripheral nerves to the spinal cord to the brain, and then the feedback system back. Sports medicine, interventional spine and musculoskeletal care, which I practice, pain management, cancer rehabilitation, pediatric rehabilitation, and cardiac rehabilitation. Just some small focuses of physiatry that you get exposure to in PM&R. You also, the great thing about being a physiatrist is you're kind of head of the house. In an acute rehab, that's where patients go with certain diagnosis after the hospitalization, because they still need recovery. There's not a safe transfer home, and they need more medical care and more functional improvement. The physiatrist runs it. So you're managing teams of occupational therapists, physical therapists, speech therapists, recreational therapists, psychologists, social workers, even other medical doctors are on your consult team. So if you like being the boss, being a physiatrist is very helpful. It is one of the most popular residencies in the United States now, and spots fill up every year. So it is a hard discipline to get into. It never used to be. One of the reasons why is it has such a high job satisfaction compared to other specialties. So, and physiatrists tend to be handholders. So we allow other physiatrists to find a good work balance many times. A lot of people have recognized physiatry a little bit more. One by Murderball, which again, it's a documentary in 2005, and I recommend you watch it. It's really good. Long COVID, a lot of the studies coming out about long COVID are specifically through physiatrists, some neurologists, but a lot of the major programs, the ones that are even working with the U.S. Department of Health and Human Services, are PM&R departments. And then I probably dating myself, but I don't know if any of you know the old Superman, the 1980s Superman, Christopher Reeves. He was Superman. He was the Superman before all of these other Supermans came out, and he had a tragic accident. He fell off a horse and had given himself a cervical spine injury. He became a tetraplegic, and he was treated at Kessler, probably by one of the most brilliant men I know in physiatry, Dr. Stephen Kirschblum. And unfortunately, he passed, and that should be a good talk for another day if anybody's interested in what happened. But he was very famous, and he really brought the field up in terms of popularity and recognition.
Yeah, hopefully he helped a lot of first responders too, because I think there were reports. I forget what I remember was that he was not like immobilized immediately, properly protecting his C-spine, all that fun stuff. So hopefully help first responders understand, like, protect that C-spine first thing, and then clear it later and take the collar off.
Yes. And, because of his philanthropy and the work between him and his wife, they raised so much money for spinal cord injury. Really just a fascinating story. But there probably is a documentary about him too. The reason I throw this slide in here is I will say that one bad part about physiatry is that they didn't have a marketing team working with them when they were creating this field. And nobody ever knows what physiatry is. And they have a very hard time saying physical medicine and rehab. And my father for years have called me a podiatrist, and I'm not talking bad about foot doctors, but I think we just need to say the words more, and we need to acknowledge what it is physical medicine and rehab is. And physiatry is fine. We just have to say it frequently and over again.
Yeah. Neurology and urology have the same issue. My wife is a neurologist, and the joke is always like, if the patient starts to drop their pants, like, no, wrong doctor. Yeah, that's a fun one.
Being a physiatrist, we'll skip through, you have to be an MD or a DO. Your internship is a year. You do a transitional year, prelim year of medicine or surgical internship. Your residency is 3 years. And then most people, although you don't have to be, you can be a general physiatrist, but most people choose to do a fellowship. They're usually 1 to 2 years. The 2 years tends to be pediatric rehabilitation, and it's needed. Peds is a whole nother world. It really is. And you kind of have to be a pediatrician at the same time.
Yeah.
I throw this in here because I do give talks, to high school students as well as college students about being a physiatrist, about being a physician in general. When you dedicate this much time to being a physician or to getting this, professional level career, you do lose income, and a lot of earned income, like these years of income where your friends are making money straight out of college and you're not. You're giving your time as opposed to getting financially reimbursed for it. But physiatry, the great thing about physiatry is there's a lot of avenues outside of even practicing that you can still make money for. And a lot of physiatrists that I know who work full time do side work and are very happy with it. They're commonly expert witnesses because we know disability reality, and we know life planning. We know outcomes and prognoses very well, and how much things cost and what services you'll need. And just being disabled, a lot of people want your expertise. So you can do life planning, expert witness, independent medical evaluations, where you evaluate people who are been involved in motor vehicle accidents and they need evaluations outside of their physician or their lawyers. Mood lighting is very common, especially during residency. And I know a lot of physicians who did this, to help make money. And you are capable of doing this. Telemedicine's optional. And a lot of physiatrists will go into what's functional medicine. And those are for your listeners who say, well, I like the term, I like complementary medicine. I like Eastern medicine and Ayurvedic medicine. And, is there a different component? And functional medicine, although it's not its own field, there's an assumption that maybe in 20 years it will be, when it's a little bit more recognized. But it's basically people who practice functional medicine, who practice it with an overall understanding of, Western medicine as well as functional medicine. It is more of a wellness as opposed to a treatment of a disorder and subsequently, trying to cure.
Yeah. And functional medicine from an MDDO side is very different than the chiropractors on Instagram that call themselves functional medicine specialists. It's very different. I said it, not you.
Fellowships. Yes, there's fellowships for functional medicine that only physicians can do. Okay.
Yep.
So for the interventional MSK spine care, if you're interested in pain, let's go back to the word pain management. So let's take it back 10 years. Pain management was the word. You had two different types of fellowships. There was ACGME and non-ACGME. The ACGME were commonly the anesthesia-based programs, okay? The non-ACGME fellowships tend to be more PM&R, although it would vary. And you are allowed to sit, if you do ACGME, for anesthesia pain boards. There's other pain boards that some states do acknowledge, and you can sit for those if needed. The benefit of anesthesia based over PM&R is, one, you get that ACGME accredited board because of the test and the fellowship. But the other thing is, you tend to do a lot of more of that chronic pain management. You'll see those patients and do those managements, those long-term chronic medication management that you not necessarily would do if you did a PM&R based. The benefit of PM&R based or non-ACGMEs is we tend to know the musculoskeletal system much better. We tend to be better diagnosticians. And it's not saying anything bad about the anesthesiologist, but when I see a patient come in with spine care, I'm looking at, okay, why is their hip thrown off? Is there a knee problem? Do they have hip arthritis? Do they have pes planus? Is that the reason for the spine having the disc herniation? You treat the disc herniation, but then you address the other issues at the other end. And that's kind of the difference between the two. Interventional musculoskeletal and spine care I put in here, and it was funny you said that. I put not pain.
Yeah.
So in interventional musculoskeletal care, what do? We're very heavy in intervention, right? So injections and intervention. It's primarily a procedural based specialty. So you tend to have higher pay and higher salaries. You get better insurance reimbursements, okay? The injections we do is anything from joints, tendons, tissues, nerve blocks, spine injections, epidurals, radiofrequency ablations where you burn nerves in the back, or the knees or the hips. Minimally invasive spine procedures can be done if you're trained well and you have that background. You can do implants and spinal cord stimulator trials. It's a lot of things you can do. Regenerative medicine tends to be heavier in our field. We do shockwave therapy, which is good treatment for musculoskeletal pain. So you'll see an overlap of pain management and sports medicine kind of combined in the interventional MSK and spine care. You do diagnostics, so ultrasound evaluations. Most of the interventional MSK and spine care now not only trains you for fluoroscopic or X-ray guided injections, but also trains you in reading and using ultrasound in order to do these injections, as well as diagnose. Electrodiagnostic, those are nerve conduction studies, probably one of the oldest things out there that we use. Neurologists are very heavy into this, but really good in terms of diagnosing people with pathology, nerve pathologies, and giving chronicity or giving a timeline for, how bad is it and what's the prognosis. You can do sports medicine practice or guide your treatment, you guide your practice towards more sports medicine athletic components. I do sideline team play. I evaluate for athletic injuries. I do ringside boxing, MD work, which is fun. And then if you want to do that advanced pain management, again, you can do that. There are things that, we see up and coming, ketamine infusions, trigeminal nerve blocks and stuff like that. It all depends on which route you want to go. So you asked me to do some cases. I'm glad that I speak fast and I'm from New York, so I can do this. But I wanted to give you a kind of a day in my life at my clinic,
Yeah.
which is called the unicorn in my clinic. And I'm just going to take 1 second to say this. Depending on what part of the country you practice in, or depending on what part of the country that you train in, you're going to see sports medicine and pain management be separate. At the Multidisciplinary Spine Center at UT Southwest, they allow me to do both of it. That's not the case in different parts of the country. Now in New York, I'm probably a dime a dozen. Down in the South Texas here, it's more subspecialized. So when you're looking into programs for medical school or even residency, you have to take into consideration where you're plan on training, because it sometimes does make a matter in what type of training you're going to get. Okay. So this is a patient that I saw in my clinic.
And we're back, but now I can't hear you. It's gonna. Oh, connected. I can't hear you. Man. Oh, there we go.
Yeah.
I got you now. I got you.
Oh, you hear me?
Yeah.
Okay. So 23-year-old male, no significant past medical history, has acute onset of severe back pain. He got it developed. He was sitting through finals. I was in bed for a few days. And then after a while, he used some over-the-counter medication, started to improve. And then a few days later, started getting some significant pain going down the left lower limb, rated down the buttocks, the thigh, the knee, into the leg. Pain was worse, was bending forward and at the waist, and with prolonged sitting. He had no weakness in the leg, but the pain was so bad when he was bearing full weight on the limb, he barely could stand. He had no loss of bowel or bladder control, no recent fevers or infections. So your approach, you're going to do a thorough history and physical examination. We always start with conservative care first, especially if there's no neurologic evidence of impairment on your exam. So you start with medication management, anti-inflammatories, NSAIDs, muscle relaxers, sometimes steroids, sometimes opiates, and rare occasions. We do physical therapy and exercise guidance. The worst thing to do when it comes to low back pain is to lay in bed. We actually advise patients to move. That's very antiquated thinking of keeping them resting. We want you to be functional. People can go to chiropractors, acupuncture, osteopathic manipulation. In the first few weeks, people find that almost anything will improve because you're so inflamed. Anything to kind of help bring down that pain and inflammation will be beneficial. We do basic imaging to start. But after you do that, in the first few weeks, you have them come back, they're still not responding. What do? They still have severe pain, or if they have neurologic impairment, we then will get advanced imaging. Sometimes we order those electrodiagnostics. So you see right now, I just added half of what we do in here, that comprehensive approach, getting other people in on your team to treat, not only medications, but therapists and even acupuncturists. Next slide. And so you get that MRI, and this is a sagittal view of your lumbar spine, MRI T2, okay? And if you notice that there is your spinal column, you're going to see a bone. Can you see my arrow moving or no?
I can draw for you.
Oh, thank you. So that is the L4 vertebral body. If you go below that, you see something, it looks like it's almost sticking its tongue out, right? It is a disc herniation that is pushing into that spinal canal. And that is the source of the patient's pain. There's two sources, most likely. You have a disc that is torn, that is ruptured, and it is now going into a region that it wasn't supposed to. You get both pain from the disc itself, as well as what we call a chemical reaction, an inflammatory reaction that inflames everything around it. And because of this, a lot of times that disc can push on a nerve, but even if it doesn't push on the nerves in that region are going to be flared, because the inflammatory reaction, your body's response to that acute injury, that new injury, is just going to flare everything up.
Yeah. And what's not shown here is that there are nerves coming out, potentially going down the leg, that we don't see, that we have to assume are there. So yeah, you have to always keep that in mind. Whoa, going backwards. All right.
So the reason I showed you that picture is I wanted to show you, well, if somebody needs an injection for it, what does that injection look like? So this is an example of an epidural steroid injection at that left L4-5 transforamen. So if you see there is a needle coming in, now, by the way, this is, it almost looks like an X-ray view. That's because we're using fluoroscopy. That long dark line going into what looks like a hole is our spinal needle. The hole that it's entering into, this is called the foramen, and that's where that nerve exits. That nerve exits that area, and it's going to go down to the muscles in the leg and supply the nerve, the muscles it's supposed to. So that is the L4 foramen. This is the L4-5 foramen, and the disc is, and the needle's coming into that foramen, and that's when you drop some dye and medication. So when you go to the next slide, you'll see, so this is now what we call an AP view. So this is your lumbar spine right in the middle. You see the needle coming in on the side, and then you see this dark hazy pattern here. Okay, that dark hazy pattern is what we call omnipaque, and that is the view of the dye actually going into the epidural space. And then you can see, if you just look right under where that dye is, you see almost like this little arch there. This is called the pedicle, and under there, other side right there, you see a dark little pattern that's going around the pedicle. So yep, perfect, right around there. And that is the dye going in around the nerve root. Not only does it go up, but it goes around. And by the way, this is called an infraneural approach. This has been shown better in the literature than doing a safe triangle. It's an infraneural approach, gets better coverage. Ventral approach with your medication, it proves them better. Anyway, I digress. The reason I show you this is because once we see that, we inject the steroid. The patient feels better. Sometimes you repeat it, sometimes we don't, but this you usually give you relief. So this is one example of one type of interventional procedure using image guidance. That's fluoroscopy. The next one I'll go real fast because I know we're running out of time.
So a student just asked a question. Is this similar or different to sciatica?
So sciatica is an interesting terminology. Sciatica is what the population uses. It's just it's a general term, because the sciatic nerve actually does not form until it's in your butt. Okay, into your gluteus, in your pelvis. But I say it forms in your butt. This is what I tell patients. The sciatic nerve is made up of many nerve roots, L3, L4, L5, S1, S2. So it has all these nerves that are together, and it is a very big, thick nerve. So when a patient uses the word sciatica, you're thinking they have pain in the lower lumbar sacral region going down their leg. Sciatica has to go into the calf or the foot. But that term, if you're talking to another physician and I hear the word sciatica, I say either they're saying what the patient's, or a true sciatica is when there's pathology in the gluteus region affecting, sometimes the piriformis affecting the sciatic nerve.
Yep. I'm glad that my love of anatomy and understanding of some of this stuff is coming to play with my drawings.
That was great. Thank you. I'm so sorry. I appreciate that. I wish I had my arrow. I was going to help out, but I can't. I'm sorry. So I'll run through the second one. And this is for those, other people who are like, I love pain management, but I love sports. Well, here we go. We have a 30-year-old female collegiate tennis player. She now plays for recreation and exercise at least 2 times a week. History of mild left shoulder pain bilaterally, treated remotely and successfully in the past with physical therapy. No other interventions, and did well. She had an acute anterior shoulder and arm. She developed acute anterior shoulder arm pain for about 6 weeks. She was increasing her amount of playing at least 3 times a week because she's trying to lose a little.
All right, we are back. I don't know what happened. I don't know if we're gonna get Renee back. We'll try. Thanks for coming back. For those of you who did come back, I don't know if we're gonna get Renee back. So, all right, I guess we'll call it. I'm sorry about that, guys. Zoom crashed on us, and it is what it is. Just that day today. I hope you all have a great day. I'll see you later. Bye.